per liter. Signs are the dehydration is present, tachycardia is present, weight loss, hypotension, abdominal pain, vomitings, and there is decreased level of consciousness in DKA patient. Mainly the children are diagnosed of diabetes firstly as they present in DKA. Management is fluid replacement, IV insulin, which we give in regular infusion drip, which is later on when the patient becomes stable, the insulin is replaced into subcutaneous injection 3 to 4 times in a day, depending on the different regimens of insulin therapy. Then we have to monitor glucose, electrolytes, ketones. Sometimes while giving correction, fluid correction, rapid correction causes cerebral edema, which is a grave sign of grave complication of diabetic ketoacidosis. So correction of fluid should be very judicial. In HHS, it is characterized by lack of ketosis. There is no ketosis, even there is no acidosis, but glucose levels are extremely high, and there is increased fluid deficiency. Type 2 diabetes mellitus people are more at risk. Presenting symptoms are similar. Treatment is also almost similar. Careful fluid dehydration, insulin therapy, and treating the underlying cause. Now coming to chronic complications, these are mainly divided into macrovascular, as including the large blood vessels, and microvascular. Macrovasculars, it affects the heart and blood vessels. It is characterized by high cholesterol, hypertension, and atherosclerosis, while microvascular complications are retinopathy, nephropathy, and neuropathy. Nephropathy, retinopathy, neuropathy, and hypertension are rarely seen in pediatric patients, but in cases of long-standing diabetes, it is seen. Now coming to nephropathy, pre-pubertal children and those in the first 5 years of diabetes should be considered at very low risk of microalbuminuria. That is the main sign of nephropathy. A first morning urine albumin to creatinine ratio, that is ACR, has high sensitivity and specificity for the detection of microalbuminuria. Random ACR ratios are compromised in adolescents because it is also present in exercise-induced proteinuria and benign postural proteinuria. So, morning sample is taken more accurate. Treatment is indicated only for those adolescents with persistent albuminuria. There are no long-term intervention studies assessing the effectiveness of ACE inhibitors and angiotensin receptor antagonists in delaying progression to overt nephropathy in adolescents with microalbuminuria. Coming to retinopathy, it is also rare in prepubertal children with type 1 diabetes, but screening should be done in patients with age more than 15 years and diabetes mellitus of 5 years. They should be screened annually. In cases of diabetes mellitus with 5 to 10 years of duration and with normal eye examination and good glycemic control, screening should be done every 2 years. Coming to neuropathy, is mostly subclinical in children. The tests that are vibration and monofilament testing have suboptimal sensitivity and specificity in adolescents. The only treatment modality of children and adolescents with is intensified diabetes management, that is attaining good glycemic control. Dyslipidemia is also seen, but it is rare in children, but also seen with cases with high risk categories. The high risk categories are longer duration of disease, microvascular complications, cardiovascular risk factors including smoking, hypertension, obesity, and family history of premature cardiovascular diseases. Screening should be done with patients of age more than 12 years, and in cases with age less than 12 years, those cases which are having the specific risk factors discussed earlier. Every 5 years screening should be done. Statin therapy has only rarely been studied, specifically in children with diabetes. Hypertension. Up to 16% of adolescents with type 1 diabetes have hypertension. Blood pressure should be screened twice a year. And we have to treat the hypertension in these cases according to the children with hypertension without diabetes. The treatment for hypertension is same in diabetic and non-diabetic patients. This slide summarizes the screening for different complications of diabetes: nephropathy, retinopathy, neuropathy, dyslipidemia, and hypertension. We discussed already. Now coming to some comorbid conditions present in diabetes. One condition is autoimmune thyroid disease. Autoimmune thyroid disease should be checked with all children with the type 1 diabetes. The screen test is serum TSH levels and thyroperoxidase antibodies. The frequency of tests should be at the time of diagnosis and every 2 years thereafter. Patients with positive thyroid antibodies and symptoms of hyperthyroidism or goiter, serum TSH level with thyroperoxidase antibodies, if previously negative, it should be done every 6 to 12 months. Second entity is primary adrenal insufficiency. In cases of type 1 diabetes, unexplained recurrent hypoglycemia and decreasing insulin requirements, the test is 8 am serum cortisol and serum electrolytes, that is sodium and potassium. Another disease, that is celiac disease. It is also very common in patients with type 1 diabetes. In cases with recurrent gastrointestinal symptoms, poor linear growth, anemia, poor weight gain, fatigue, and unexplained frequent hypoglycemia and poor metabolic control, the test done for celiac disease is tissue transglutaminase levels and immunoglobulin A levels. These three entities, autoimmune thyroid disease, primary adrenal insufficiency, and celiac disease, are common in pediatric patients with type 1 diabetes mellitus. That is all from my side. Thank you for having me.
Thank you, Dr. Anjani, for such a wonderful lecture. I now request Dr. Toshi to please introduce our next speaker.
Thank you, Dr. Manisha. It's my pleasure to invite Dr. Kavita Chatterjee. She is former professor and head Department of Oral and Maxillofacial Pathology at Buddha Institute of Dental Sciences and Hospital, Patna. She had a brilliant academic career throughout. She has to her credit a number of research papers and she has authored various reputed textbooks. She is also a part of the Cancer Research Project at Chittaranjan National Institute, Kolkata. Thank you, ma'am.
I would like to discuss about the oral complications of diabetes mellitus. Diabetes mellitus is a growing public health concern and a common chronic metabolic diseases worldwide. It represents a group of metabolic diseases that are characterized by hyperglycemia due to a total or relative lack of insulin secretion, insulin resistance, or both. Diabetes mellitus is associated with several microvascular complications like retinopathy, nephropathy, neuropathy, and macrovascular complications like cardiovascular and cerebrovascular diseases. It affects all age group, commonly adult. WHO declared it to be pandemic recently, and according to International Diabetes Federation, globally the prevalence of diabetes mellitus has increased dramatically and expected to increase threefold in next decade. The abnormal metabolic disorder in diabetes mellitus exert its damaging effect on endothelial cells and nerve cells. Hence, there is susceptibility on the tissues where there is extensive vascularization and innervation, like the eyes, kidneys, nerves, etc., are commonly affected. Oral tissues are highly vascularized and innervated, so oral complications in diabetes mellitus also expected as well. The pathogenesis of these complications are complex and involves metabolic hemodynamic disturbances, including hyperglycemia, insulin resistance, dyslipidemia, hypertension, immune dysfunction. These disturbances initiate several damaging processes, such as increased reactive oxidative species, that is ROS production, inflammation, and ischemia. Now, oral manifestations of diabetes mellitus vary in its severity in relation with blood sugar level. It can be as simple as normal gingivitis or xerostomia to a devastating opportunistic infection like mucormycosis candidiasis. Potential oral complications are gingivitis periodontitis. It is proposed as sixth most prevalent complication. Now, due to lack of saliva and more bacterial growth in the oral cavity and more carbohydrate content of saliva, and there is reduced cleansing capacity of the saliva, leads to unhealthy red swell gingiva. There is severe bleeding from gingiva past deposition, and there is gradual mobility of tooth. Next common complication is dental caries. It is also very much prevalent in diabetes mellitus due to increased blood sugar level, increased sugar level in saliva, decreased cleansing and buffering capacity of saliva, and high bacterial growth in plaque, that is mostly streptococci and lactobacilli in plaque. Dental caries leads to pulpitis and pulpal necrosis. Another important complication is xerostomia or dry mouth, and this is due to salivary dysfunction. Reduced salivary flow rate is more in patients who have developed neuropathy. Neuropathy, microvascular abnormality, endothelial dysfunction may lead to deterioration of microcirculation and play a role in reduction in salivary flow rate and change in saliva composition. There is a scarcity of saliva and it becomes thick and ropey. Situation is aggravated by antihypertensive drugs, tobacco smoking, and old age. There is excessive bacterial deposition in the saliva, and that leads to xerostomia, polydipsia, polyuria. Dry mouth leads to more caries, periodontitis, fissured tongue, soreness of oral tissues, difficulty in biting, talking, chewing, swallowing, and burning sensation. Now, sometimes in diabetes mellitus, there are asymptomatic, non-inflammatory, non-neoplastic swelling of bilateral salivary gland, which is known as sialosis. Next is neurosensory oral disorder, which is also known as oral dysesthesia or burning mouth syndrome. This is also quite common in diabetic neuropathy. Nerve damage leads to increased population of the Langerhans cells associated with immune disturbances. It is also associated with the tingling, numbness, dryness of mouth, and very painful sores in the oral mucosa. Another important complication of diabetes mellitus is fungal infection. Mostly there is oral candidiasis. It is also very much prevalent in diabetes mellitus. It's aggravated with the smoking, use of denture, prolonged steroid and antibiotic therapy, and due to salivary dysfunction. It is usually characterized by dense, thick deposition, white deposition or plaque on the dorsum of the tongue, buccal mucosa, palate. Now, sometimes there is total depapillation of the tongue with the erythematous changes of the tongue, erythematous changes of the palate, and sometimes there is ulceration at the angle of the mouth, which is known as angular cheilitis. Diabetes mellitus is also associated with bacterial infection. Immunocompromised patients with poor metabolic control are more prone to spread bacterial infection. In diabetes mellitus, the wound healing is very poor due to poor soft tissue regeneration and delayed osseous healing in diabetes. Now, these complications are very much prevalent in oral surgical procedure. So, management and treatment of patients with diabetes undergoing oral surgery is very complex. Delayed vascularization, reduced blood flow, reduced innate immunity, reduced growth factor, psychological stress may be involved in protracted wound healing of oral tissues with diabetes mellitus. Now, due to less salivary flow and bacterial growth in the oral cavity and less flushing mechanism of the food material, there is halitosis. And metabolic, endocrinal, and salivary dysfunction can contribute to altered taste sensation. Another very important complication of diabetes mellitus is the oral mucosal disorder. It is usually associated with lichen planus or lichenoid reactions, and these are mostly found in type 1 diabetes. Acute hyperglycemia causes alteration in immune responsiveness in diabetes mellitus. Atrophic and erosive lichen planus are more common in patients with type 1 diabetes. Other than lichen planus or lichenoid reaction, there are very painful aphthous stomatitis, traumatic ulcer, irritation, fibroma, benign migratory glossitis, and fissured tongue. Now, many a time there are temporomandibular joint disorder, possibly with involvement of microvascular damage. Now, oral cancer and potentially malignant lesion, the association with diabetes mellitus is very much debatable. According to some school of thought, diabetes mellitus is associated with the oral cancer, but in other reported cases, there is no definite relationship between oral cancer and diabetes mellitus. Anyway, diabetes mellitus is causing higher risk of mortality in oral cancer. Now, there are peri-implant mucositis and inflammation of the supporting bone in implant in relation to diabetes mellitus. And if there is advanced periodontitis with severe loss of periodontium, there may be loss of tooth. Now, oral manifestations of diabetes mellitus, they are reliable indicator for undiagnosed diabetes mellitus in patients. In those cases, dental surgeons can play a pivotal role by taking history and thorough oral examination. Now, in undiagnosed diabetes mellitus, many a time patient complains of polyuria, polyphagia, polydipsia. And along with that, if dental surgeon finds there is advanced periodontitis, dryness of mouth, surgeon should advise for HbA1c test and other relevant tests to detect diabetes mellitus. And in that case, it is very much essential to prevent the preoperative and postoperative complications of diabetes mellitus. In diabetes mellitus, with oral complications, some precautions are to be taken, like to keep blood sugar level within limits, to maintain oral hygiene by brushing, flossing, rinsing with antiseptic solution, removal of denture at night and proper cleaning of denture, to quit smoking, and periodical dental checkup along with ultrasonic scaling. Diabetes mellitus is the chronic non-communicable endemic disease. Oral manifestations and complications in patients with diabetes mellitus have been recognized as a major complication of diabetes mellitus. The chronic oral complications in patients with diabetes mellitus affect blood glucose level. Prevention and management of oral complications are important due to their adverse effect on glycemic control. Diabetic oral complications need to be identified and included in ultimate care of diabetes in order to fight the chronic metabolic disorder. Thank you.
Thank you, Kavita ma'am, for elucidating upon the oral complications of diabetes. I now request Dr. Gyan to please take it from here and introduce the next speaker.
Thank you, Manisha ma'am. It's my pleasure to introduce Dr. K. Badna Desai ma'am. She is the chairperson for MBS Periodontics Syllabus Formation, board member of UG, PG, PhD committee at Rajiv Gandhi University of Health Sciences. She has had a brilliant academic career for more than 35 years. She is also working on autologous stem cell research in periodontal regeneration. Thank you for taking out your precious time, ma'am. Welcome you, ma'am.
I'm a teacher of periodontics, an adorable and unapproachable subject in dentistry. My journey of dentistry began from Government Dental College as an undergraduate student, completed my BDS from there, and the first MDS graduate from Bapuji Dental College and the hospital, a proud alumni, and continued as a teacher from Bapuji Dental College and Hospital and College of Dental Sciences. I thank the management immensely and always indebted to Mr. Vishwaradhya and Dr. Shivshankarappa. Today's topic of presentation is periodontal complications of diabetes, how each disease very disturbing to the human kind, periodontitis as well diabetes, they go along, get to see. Complications of diabetes mellitus. The sixth complication was introduced by Harold Lowe in 1993 in the journal Diabetes Care, along with other complications. In this picture, we are able to understand better from the eye to the toe, various parts of the body are affected as a diabetic complications if untreated or uncontrolled. The sixth complication of diabetes is accompanied by severe gingival inflammation, deep pockets, rapid bone loss, and frequent periodontal abscess, especially multiple in nature, is a diagnostic criteria often to the periodontist, and referral to the blood investigation usually results in diabetic status for the patient, which is unknown to him. In general, the oral manifestations are due to diminished salivary flow that results in burning, mouth and the tongue, the mucosal drying and cracking, chelosis. Adler et al. Reported the change in the alteration in the flora of the oral cavity with a higher predominance of Candida albicans, hemolytic streptococci and staphylococci, which may result in increased dental caries. Periodontal manifestations has been given by Hirschfeld as early as 1934. So it's not a new entity at all. It's been there from 1934, much earlier. In the periodontitis status, the changes in the gingiva are usually enlarged, and it could be sessile or pediculated in nature and polypoid also in nature. Loosened teeth or the mobile teeth are characteristic of periodontitis. Very characteristic is the abscess formation, multiple in nature. Now, clinical presentations of this condition, diabetes associated periodontitis, we have generally the periodontal bone loss, much higher than those from the non-diabetic patients, and the changes in the gingival inflammation and as a form of enlargement and multiple abscess could be appreciated. Effect of diabetes on periodontium can be appreciated in further slides. There is a shared risk factors for periodontitis and diabetes given by Kocher et al. In Periodontology 2000 in 2018. The age, sex, socioeconomic status as the demographic factors and other related factors like risk factors, smoking, microbiota, genetics, and obesity form a common platform. The two-way relationship between periodontal disease and diabetes mellitus due to hyperglycemia and age and rage reaction. There's a formation of inflammatory mediators, TNF-alpha and interleukin family. These are degradative cascade forming collagenase and various other enzymes which can destroy connective tissue. Similarly, in periodontal disease, the source is periodontal pathogens due to endotoxins and toxin production. The pro-inflammatory cascade is stimulated, generating TNF-alpha and interleukin family. This can lead on to connective tissue destruction. So they interact each other due to the various arrow marks you could get to see here. Basically, the pro-inflammatory cascade is common factor. This was pronounced by Brasheau et al. In the Diabetologia in 2022, trying to have a two-way relationship. Association between periodontal disease and diabetes were also extended by Taylor in a Journal of Periodontology, a well-known journal in our field of periodontics. In 2030, he added up oxidative stress, branchial OPG axis, and basically the fat metabolism also leading on to adipokines and leading on to, again, the center of attraction is the pro-inflammatory mediators, increased TNF-alpha and interleukin families, and these can shift the subgingival biofilm ecology and resulting in enhanced tissue destruction. Impaired tissue repair is always associated with diabetes, which can enhance to degradative changes in periodontitis. So diabetes and periodontitis, two ends, have been commonly linked with through hyperglycemia and the common factor being the cytokines, pro-inflammatory mediators. Now, next to the association between these, the main culprit is being the ages, advanced glycation end products due to hypoglycemic status. And cytokines and adipokines also play a very important role in the destruction, as suggested by Taylor JJ. In the diabetic gingiva, as compared to normal gingiva, we can tell about increased gram-positive and gram-negative bacteria in the pocket area, various cytokine structures, and also the various cells, inflammatory mediator cells which are present, and then the osteoclastic resorption at the bone. These are the general changes that occur in a periodontitis patients with the diabetes. Also, to go further, the age is being represented here in the whole of the gingival tissue, and the age with age and rage, activating endothelial macrophage fibroblast cells can exaggerate the response to periodontal pathogens, resulting in accelerated destruction of the soft tissues and bone in the diabetes. In general, I would say life process, this age, and the rage are always destructive, even otherwise not only in this state. Age and periodontium, along with its influence, periodontal microbiota along with the rage activation would lead on to exaggerated and sustained inflammation in the soft tissues. And this, along with the impaired repair, will enhance the periodontal tissue breakdown, trying to correlate with diabetes mellitus in periodontium. A study by us in 2011 we were trying to check out using a polymerase reaction various odoriferous subgingival and tongue microbiota based on the acetone breath, which is quite common in the diabetic patients, and also diagnostic from the periodontal clinic. Most of the patient is unaware of this. And sometimes probably some over-responsive patients can also say their breath is not being all right. So in this case, in this study, we were able to show Porphyromonas gingivalis, Fusobacterium nucleatum count was found to be higher in subgingival plaque of the diabetics, whereas FN count was more in the tongue scrapings of the non-diabetics. This was quite an interesting study for us in 2011, published in Indian Journal of Dental Research, a PubMed journal. Now, another study by Sangeeta Veer, it's a consensus report actually, presented in PubMed journal, Indian Society of Periodontology, where it has suggested that pre-diabetics and diabetics have a higher chances of developing periodontal disease, and vice versa. Periodontitis also have a higher chance of developing pre-diabetes and type 2. To get proved or further confirmed, we need a very long-term studies, and that is a need of the hour. The mechanistic link between diabetes and periodontitis generally speaks about the role of microbiota, neutrophils, T cells, monocytes, and the cytokines, along with altered collagen synthesis, and the role of oxidative stress plays a very vital role in destruction during diabetes and as well periodontitis. To conclude, I would like to say the basic culprit is those cells, innate immunity cells, monocytes and macrophages, resulting in pro-inflammatory mediators, causing insulin resistance for the diabetes, and periodontitis itself being influenced by due to the hyperglycemic status, the pro-inflammatory mediators which are produced. Basically, they have a similar pathogenesis or the pathogenic mechanisms which try to influence each other to worsen. I would say that all diabetes patients do not have periodontitis, all periodontitis patients do not have diabetes. One common factor which does not gel in both these conditions is in diabetes, if self-motivated patients, if they can have a good control of the taste buds, the diabetes can be prevented to progress, prevented to have complications, and the morbidity also. Whereas in periodontitis, it is not so. Even the control of the taste buds, it doesn't help, but of course, plaque control is the mainstay in the prevention of progression of periodontitis and its complications. So periodontal complications of type 2 diabetes based on various influences of the risk factors. With this note, I wish to say diabetes and periodontal diseases are a common enemy to you. So try to have a control on diabetes and periodontal disease. Both the diseases are, once started, it's difficult to prevent. Once started, it is difficult to complicate if you do not have a good management of them. Both of them are non-controllable if you do not control them. Gratitude. This slide speaks of the gratitude. I would like to say my parents who made me disseminate this knowledge globally, especially on our online platform. And I love the online platform because it saves a lot of time, energy, and my way of sharing knowledge through the paper is quite interesting. And my family, Dr. Desai, oral maxillofacial surgeon, and my software engineer son, always helps me to go digitally and makes me do better things. And any feedback you would like to have, it is there, manraj@gmail.com. And I immensely thank all of you for the patient hearing, and very briefly and very crisply. And I wish to thank Dr. Anandita, who has been very supportive for this diabetes lecture. And her present persona, I'm sure, would be a great asset to the college as an HOD, a great support to the students as well as the staff members. thank you once again for giving me this opportunity to speak and share the knowledge in a very crisp way. Thank you one and all. Take a good care and take a good care of others.
Thank you, Vandana ma'am, for such a crisp yet informative lecture. I now call Dr. Sashwati to introduce our next speaker.
Thank you, Dr. Manisha. Now I would like to cordially welcome our eminent speaker, Professor Dr. Jivendranath Shukla, to this webinar. He is an MDS in pediatric dentistry. Sir has a teaching experience of 20 years as faculty in various dental colleges in India. He has more than 20 publications in different national and international journals. Sir has a clinical experience of more than 25 years in dentistry, and he is currently working as professor in Department of Pediatric Dentistry, Buddha Institute of Dental Sciences in Patna. We are very happy to have you here, sir. Welcome you, sir.
Complications of diabetes mellitus in pediatric patients. The contents. Diabetes mellitus is a group of metabolic diseases characterized by chronic hyperglycemia resulting from defects in insulin secretion, insulin action, or type 1 diabetes mellitus is one of the most common chronic diseases in childhood resulting from autoimmune destruction of the pathogenesis. Severe insulin deficiency caused by the autoimmune insulitis, and due to which that the type 1 diabetes mellitus occurs in children. Clinical features, general clinical features, and the oral manifestation of diabetes mellitus. These are some oral manifestations: salivary gland dysfunction, oral microflora changes. Salivary gland dysfunctions, there are both quantitative and qualitative changes in the saliva of diabetic patients. Diabetes are considered to have a reduced salivary flow, especially that of unstimulated saliva. It is also called xerostomia. The study by some Moira observed that the unstimulated salivary secretion in children with diabetes versus the control group was 0.15 ml per minute to 0.36 in control ml per minute, respectively. So there is reduce in the secretion of the saliva, as quantitatively and qualitatively the parameters also changes. There are some increased value like viscosity of saliva increases, level of the carbohydrate of glucose and the total protein in the saliva also increases. Increase in level of IgA or IgG also increases. There are some decreased values also there of saliva as the buffering capacity of the saliva. pH of saliva also decreases, and level of the antimicrobial proteins for the things like lactoferrin and lysozyme, these also increases. So overall, there is some dysfunctions which also lead to a lot of problems associated, like parotic hypertrophy. One of the very common complication in the diabetic children is the parotic hypertrophy is non-inflammatory, non-neoplastic hypertrophy. And damage to the ventromedial nucleus of the hypothalamus results in a parotic hypertrophy in diabetes patients. Samuel B. et al. Found 48 individuals, like 24% with asymptomatic parotid gland enlargement in study of 200 patients with overt or latent diabetes. All individuals with enlarged asymptomatic parotid gland should be tested for the diabetes mellitus because it's quite common. And there is oral microflora changes and dental caries is there. And the level of the Streptococcus mutans, Candida lactobacilli species in the oral cavity are higher in the diabetic patients. Dental caries affect 60 to 90% of children worldwide, and this is the most common chronic oral disease. There is preliminary evidence suggesting that the poor glycemic control, poor oral hygiene, poor saliva quantity, plaque accumulation, poor dietary habit is related to a higher experience of caries. Some scientists report that higher caries experience is very common in poorly controlled diabetes children, like around 10 to 15 years of the age in Kuwait, India, and Puerto Rico. In contrary to above study, Lal et al. Also showed that the lower prevalence of the dental caries in deciduous dentition in diabetic patient if the sugar level is properly well controlled, and some dietary changes also there, due to which there is less incidence of the caries also for. Impaired immune responses like hyperglycemia caused by diabetic mellitus can lead to microangiopathy. Endothelial cell lining blood vessels form more glycoproteins on their surface, and there is change in the basement membrane goes thicker and wider. The vessel wall becomes thick and weak and bleed easily and leak proteins. And deranged polymorph cells is also a problem, and stimulates production of the cytokinin due to inflammatory mediators and elevate level of pro-inflammatory mediators in the gingival crepuscular fluid. These all leads to the change in the immune response. There it is impaired, and delayed occurs in healing. Gingivitis is also there. Periodontitis and fungal infections are quite common in such patients. Gingivitis and periodontitis also one of the common complications of diabetes mellitus, especially found in the children, is very common. There is about 3 times higher risk of gingivitis and periodontitis in diabetic children, and it is being labeled as the 6th chronic complication of diabetes. The onset and progression of periodontitis flora and disorders in collagen metabolism. And there is hyperglycemia has also an indirect adverse effect, stimulating the immune system cells to release the inflammatory cytokines. There is necrotizing ulcerative gingivitis, which is also a type of gingivitis, which is relatively little is known about this epidemiology of the necrotizing ulcerative gingivitis lesion in adolescent population. Some studies says that the student there is a high students were given a clinical oral examination, and they found that due to smoking and other oral habit changes, there is a pattern in found of necrotizing ulcerative gingivitis in diabetic patients. They found diabetic was positively associated with the presence of necrotizing ulcerative gingivitis. Impaired tooth eruption, that is also a common complication in diabetic children. Some scientists like Alter et al. Observed that the children with diabetes who were less than 11.5 years old had enhanced dental growth, but older diabetic children experience a setback in dental development. Some other study done by the Orbeck et al. Found that the teeth eruption was more rapid in diabetic patient with an age range of 5 to 10 years. Almonde et al. Says that reported that diabetic patients had more teeth eruption acceleration in comparison to the healthy individuals in early mixed dentition period. And so there is a biphasic effect of diabetes on the tooth maturation. In early stages, it usually there is acceleration in tooth eruption, whereas in later stages there is a slow or de-acceleration of the tooth eruption is also found. In molar incisor hypoglycemia is also a very common diabetic complication in children. It can cause the chronic hyperglycemia and aggravate the oxidative stress, which can affect the tissue structure, function of the body, and protein metabolism, as according to the Zico and Crowley. And they found that the molar incisor hyperplasia was present in 19.2% children and adolescents with type 1 diabetes, compared to an estimated global prevalence of all healthy children at 13.5%. Loops et al. In 2021. Some common finding also like burning mouth syndrome is there, where there is idiopathic causes or secondary due to the known precipitating factors, one of which is diabetes mellitus. Burning mouth syndromes has been associated with poor glycemic control, neuropathy, angiopathy, metabolic changes in the oral mucosa in diabetic individuals. Symptoms improve when the metabolic management is appropriate. Another finding which is also there, some complications like irritational fibromas. These lesions were assumed to be the result of an increased rate of tooth loss, and a great proportion of individuals with type 1 diabetes who wore dentures The character traits of type 1 diabetic patients that were attributed to irritant fibroma were having overt neuropathy. And there's some studies like James Guinheimer et al. They did the study and they found that 3 out of 10 patients with type 1 diabetes had irritational fibromas. Angular cheilitis, which is also one of the common complications due to impaired healing, impact by there is labile commissures are significantly impacted by angular cheilitis, which is persistent inflammatory condition, and clinically it appears as fissured erythematous lesions mostly around mouth angles. It is frequently bilateral and symptomatic. And some like geographic tongue is also there, where it is well known inflammatory disease that generally affects the dorsal surface of the tongue mucosa. The lesions can be solitary or numerous, intermittent or continuous, and show up as non-ulcerated patches in the clinical picture devoid of keratin. The prevalence of tissue type HLA B15 has been shown to be higher in atopic patients with benign migratory glossitis and in patients with type 1 diabetes mellitus than it is in the general population. The prevalence of type 1 diabetes was shown to be 4 times higher in George P.'s research of 87 diabetic patients, and in control group, there is the higher incidence in diabetic patients. Oral candidiasis. In diabetic patients, the major pathophysiology and nutritional relevant sugars, other simple carbon sources such as glucose and fructose are important in the growth of the Candida species. Mann et al. Looked at the growth rate of Candida albicans in the presence of various amounts of glucose and fructose and its probable relationship to the diabetes patient hyperglycemic state. And some researchers found that the glucose content is closely associated with Candida albicans development, which might explain the frequent yeast infections seen in the uncontrolled diabetes individuals. Interestingly, fructose inhibited Candida albicans growth. That is also coincidental. Some findings are also there. Prevention is also important to stop all the type of complications. Usually, they should be twice brushing with the fluoridated toothpaste, and especially with the higher ppm of fluoride in the toothpaste. In case of dental caries risk patients, fluoridation should be done in dental office 3 to 4 times a year. In daily use, there should be a mouthwash and fluoridated toothpaste should be used. And in patient at risk with the periodontal disease, the dentist should give special oral hygiene guidelines and may prescribe oral antiseptic solutions as part of the treatment. The diet that children with diabetes mellitus should follow use strict instructions should avoid frequently consumption of carcinogenic food with high levels of the carbohydrates or sugars, and assessment of risk of disease progression, periodic reviews, dietary advice, and periodontal therapy. That is also for prevention we can use. And sometimes we have to use the antifungals like Mellitus. So to conclude, diabetes mellitus have a significant impact in delivery of the dental care. And it is important for dentists to be familiar with the medical management of the patients with diabetes mellitus and to recognize the signs and symptoms of undiagnosed or uncontrolled disease. So dentists should contribute to the maintenance of optimum health in patients with this disease, and they have the potential and the responsibility to assume an active role in the early identification. So if we can interrupt or prevent this type of the complications in diabetes mellitus children by controlling the disease by proper oral hygiene, proper habit of brushing and proper care and the food changes, these all are lead to the better oral health and have the lesser chance of the diabetes complication in the oral cavity. Thank you.
Thank you, Shukla sir, for such an informative lecture. With this, we come to an end of the wonderful lectures explaining the multitude of damages that diabetes can cause in human body. I now request Dr. Neetu Broto Viswas, professor in the Department of Periodontics and Implantology, to please summarize the topic.
Thank you, Dr. Manisha. Good afternoon, everyone. It has been a truly enlightening and productive series of lectures filled with information on the topic of diabetes. Truly speaking, it is not easy to summarize today's webinar on diabetes because all points and all information are important. But it is for sure that diabetes is a serious health issue and cannot take it lightly. From the lectures, we have learned about the global burden of diabetes and its alarming increase in its prevalence in recent years. Especially type 2 diabetes is the largest global health crisis of 21st century. All our speakers stress more on the risk factors related to the development of diabetes. They are job-related lifestyle, unhealthy diet, and genetic factors also play a major role in the development of diabetes. Furthermore, our speakers also discussed the significance of regular health checkup and early diagnosis in preventing the complications of diabetes. Proper management may be done through medication, diet, exercise, and lifestyle modification. Diabetes has also a role on the psychological impact of the person. Our cardiology speakers, Sir Dr. Vikas Singh, remarked and compared that diabetes is as dangerous as myocardial infarction in normal person. Individuals with diabetes may have various heart diseases like ischemic heart disease, may have high chances of heart failure or stroke. These complications can result in death of at least 50% of patients with type 2 diabetes. He also quoted the importance of dietary and lifestyle manifestation in reducing the cardiovascular risk. Our nephrology speaker, Sir Dr. Amresh Krishna, informed us regarding diabetes and chronic kidney disease. It is now the most common cause of kidney disease and may lead to end stage of kidney failure if not treated in time. Early good blood sugar control, blood pressure control may reduce the risk of having chronic kidney disease. Our ophthalmology speaker, Sir Dr. Vibhuti Prasanna Sinha, mentioned that diabetes is gradually becoming the leading cause of diabetic retinopathy. The reason is that the patient often delayed in seeking treatment. So the best preventive measure is its early detection. All individuals having diabetes should undergo retina evaluation by an ophthalmologist regularly. Our nephrology speaker, Dr. Orun Kedia, talked about diabetes neuropathy. Prevention of this requires patient education about food care, prevent cuts, injury, deformities, and should look for any temperature and sensory changes once a patient is diagnosed with diabetes. Erectile dysfunction, cognitive dysfunction, Alzheimer's disease are other neurological complications which need to be considered beyond diabetic neuropathy. Diabetes is also a problem for children. Our pediatric speakers, Dr. Anjali Kumar, said that children are more prone to acute complications unlike adults. Now, often children with diabetes are diagnosed for the first time after an episode of acute complications. Timely screening of complications and comorbid conditions are of utmost importance. Dr. Kavita Chatterjee ma'am discussed the problem in oral cavity in diabetes patients. Patients of diabetes often complain of dry mouth leading to increased accumulation of bacteria, which in turn cause periodontal inflammation. Increased sugar level in